Hello, everyone. I'm Dr. Kimberly Madison, a doctorally prepared nurse practitioner and one of your hosts of the Melanin Initiative podcast. Today, I'm back for what we're calling One Topic at a Time, and that topic is weakness, or what we call deconditioning in healthcare. This is somewhat of a follow up to the last video I posted on physical therapy. So, deconditioning, what we're referring to is that whole phrase, if you don't use it, you lose it. So first, let's talk about what happens when you are walking, or you are ambulatory, or you are active. So when we're walking, our muscles contract, and that sends blood back to the heart. When we're standing and we're walking, we're bearing weight on our bones, and that force stimulates more bone development. That's why we always encourage people when we're talking about exercise is to do those weight-bearing exercises to make your body have to work a little bit harder than it's used to. If it's used to carrying around 150 pounds on a daily basis, you need to stimulate it to do just a little bit more. And that's where weight training becomes really essential to maintain that bone density, to avoid things like osteoporosis, and just to help you with your strength overall. As we get older, most of our body functions start to decrease, but our bones in particular are one of those things that people typically associate with aging. And so, when you're 30 years old, you're 6'1". By the time you come see me and you're 70, 80, you're not going to be 6'1" anymore. That's how, if you think about some of our older adults, maybe you notice they're more petite, they might be more bent over than in their younger years. Some of that has to do with lifestyle, and some of that has to do with aging, and whether or not they participated in a lot of weight-bearing exercises. When you're walking and you're moving, blood is flowing. It's going to your bowels, and that's helping to stimulate movement, helping you to have a regular bowel movement. When you're walking and you're standing, your lungs are fully expanded. Your diaphragm, which is a thin piece of tissue right below the lungs, can move like it's supposed to, and all your lungs are able to participate in the exchange of oxygen. And one of the things that we see in the respiratory tract, respiratory referring to breathing, or you might hear pulmonary, are these little tiny hairs, and they help to move secretions. So we always have the secretions building up in our lungs, but they're always moving out, particularly if we don't have anything like asthma or COPD, or we don't do anything to interfere with that, like smoking or getting exposed to toxic chemicals. And so all those secretions, they're moving up and out. And when we get sick or other things happen, sometimes they build up. Let's see, when we're walking, typically we're active, we're doing stuff. It's keeping our mood elevated. And so those are some of the things that walking can really do for us. So now let's talk about when we're not feeling well. This can happen at home. It can also happen it's very common in the hospital. So when people either are coming from home or they've been in a facility for a long time, maybe that's a hospital or rehab or a long-term care facility, and they haven't been moving a lot. And a lot, it can be relative depending on where their health was before, their age, any medical diagnosis that they might be living with, any treatments they might be undergoing. But we might call them, what we say, failure to thrive, which means they're not making progress. And typically what we see when we see that is they're not eating, they're not moving, they may not be doing a good job taking care of themselves. They might require other people to assist them. They're not participating in care in other ways. They're not asking questions. They're not motivated. And this can be for a lot of reasons. When certain diseases start to progress or get worse, or as we get close to, the end of life, that's a real part of life, is that, we're all going to die. And so as we get closer to that, that's a common thing that we see. It doesn't happen all the time, but it's very, very common. So all those things, picture all those things I just talked about when you're moving. Let's talk about what happens when you're not moving. So when you're in the bed or you're laying down, this can be at home. This can be at home, but we're going to focus on the healthcare setting. So if you're in the hospital and you're laying in the bed, which is what most people are doing when they're in the hospital, they're only getting up really to go to the bathroom and maybe to sit in a chair to eat. But most people are spending a lot of their time in the bed. And so when you're in the bed and you're laying still, the blood has a tendency to sit because you're not contracting, and it has a tendency to clot. And so in terms of the contracting, sometimes we'll say, do pump your feet, move your legs around in the bed if you're going to be laying flat, if you're not allowed to get up. And so has a tendency to form clots. And so we give most people what we call a blood thinner if they're not already coming in with a bleeding condition, or there's no other reasons that would make it not safe. And so those blood thinners can be in the form of a really tiny little needle. And the medication is called heparin. So that really tiny little needle will be injected in a part of the body that has fat. Typically, that's like the back of the arm or the belly, just depends on the person's anatomy or their structure of their body, where their fat is distributed. And they have the option to choose what they prefer. But the great thing about the fat is that there's very few nerves there. And so for most people, they won't feel it. We try to distract you with other things so that you won't feel it. But that medication, heparin, like I said, it's a blood thinner. And what that really means is that it increases the length of time it takes for your body to clot, so that you don't get blood clots, because that's what we're trying to avoid, since you're not moving and the blood has a tendency to sit in one place. This can happen anytime you're in the hospital, if you're sitting at home and you're not very active, and if you go on long trips. It could be one long trip, or it could be maybe you travel very frequently. And so to combat that, we might ask you to wear some compression stockings, or we have in the hospital those sleeves that we put around your legs, and they can massage your calves. Some people like it, some people don't. And they can pose to be a safety hazard. So if I have patients who tend to get up a lot and don't ask for help when they're getting out of bed, I might take them off, just because, if they do happen to get out of bed and they're really quick and they get up before we can get there to help them, now they're attached to something. And that attachment can make, if they are going to fall, make that fall or that injury even worse. So in addition to heparin, another little medication we might give is called Lovenox. It's also another little needle. So with heparin, we typically will get that every 8 hours. And the reason we really like that medication in the healthcare setting is because it gives us a lot of control. We know that in about 8 hours, its effect is going to wear off. And so if we need to take you to surgery, or if you start to develop complications, like maybe you're starting to have bleeding from some other cause, we can stop it, and we know that it's not going to make things worse. Whereas with Lovenox, that's for the most part twice a day, maybe once a day, just depending on what's, your body weight and what's going on. Again, it's a little needle we put in the body part of the body that has fat. And that is a medication that actually some people might go home on, particularly if you came in with a really big clot or developed one while you're in the hospital. And we'll do some teaching in the hospital and we'll have you demonstrate how to do that injection, because we need to make sure that you can do it. Because, the other side of that is, if we send you home and you can't do it, then the chances of you developing another clot and having to come all the way back to the hospital, sit in the emergency department, go through the workup, get imaging, go through all those questions all over again. I'm pretty sure you want to avoid that. Plus, there can be some pain associated with blood clots. Most people, when I ask them, when I try to encourage them to be more active or do certain things to avoid blood clots, and they say, that it's not something they really need to worry about, one of the things I'll say is, do you know anyone who's ever had a blood clot, or do you know what to look for? And most people do not. And so one of the most common things you'll see is that, so the legs are a pretty common place to get a blood clot, but you can get them anywhere: legs, arm, in your belly, in your lungs, in your heart, and of course, your neck and your brain. That's how you get strokes. So if you get one, let's say if you get one in your leg, what's typically going to happen is, now you have this blockage, which is, if you've watched our high blood pressure episode, which I do want to thank you all, that episode is quickly becoming one of our most popular episodes. In that episode, we had some graphics up. I showed you what a healthy artery looks like. And so imagine that healthy artery or even a water hose, if you were to bend that in half. Now, your blood vessels don't typically bend in half, but what's happening is now the blood can't flow. So just imagine instead of bending it in half, there's just something blocking it. Well, if you got all this fluid, all this blood coming, and now it can't go anywhere, it's just going to build up. And so what we see is a lot of swelling. And if you put those two extremities together, those two limbs, it's going to be quite noticeable. And so again, you have all that fluid building up, you've got swelling. It will, for the most part, it's going to be red, warm, because you've got blood. Helps warm the body. That's one of the things that it does. So if you've got a whole lot accumulating, it's going to be very warm, especially if you compare it to the other side that's not affected. And typically, for most people, when they have a blood clot, it's on one side of the body, but you can have it on both sides. So that's definitely a possibility. And now it's building up. So you got all that extra fluid pushing up against those nerves. There's going to be some pain. And then it could restrict your mobility. You might not be able to move it as well as you like. Those are the most common symptoms you'll see. So the same thing, whether it's the leg or your arm. And then if it's in the lungs, typically what people have experiences like shortness of breath. So again, if you're laying flat, blood has a tendency to sit, then it has a tendency to clot. To avoid that, we will use a blood thinner. Might be an injection, and we also have some pills that we'll use. We might start you on an injection in the hospital. So in addition to the injection, we might hang a fluid called heparin in a little bag attached to a tube that goes into that catheter somewhere in your body. And with that medication, initially we'll do a lot of blood checks because we need to be in a therapeutic range where we want to control like how long it takes you to bleed. We don't want you to bleed too long. We also don't want you to have any blood clots. And so with that medication, we might start you on that one. Or if you at home you're taking a blood thinner, we might stop it, put you on this one if you're going for a procedure. And then when you come back from that procedure, or once you get to that therapeutic range, then we'll transition you to a pill and you can go home on that pill. Some pills require frequent blood checks. So even outpatient, your provider might send you to get your blood drawn pretty frequently. Some of our newer blood thinners don't require that. They all come with risk. The most common risk we'll see with blood thinners is the ability to bruise very easily. Just bumping my elbow on the rail of the bed, I might bruise really easily, especially if we're older and we have really thin skin. Those blood vessels are just so close to the surface that it doesn't take much. Of course, it's going to take you longer to clot. And so if you cut yourself or we cut you, you might have to hold pressure longer than you're used to. If you get a nosebleed, it might last a little bit longer than normal. But if you ever see blood in your urine or your stool, or you're coughing up blood, that's never an expected finding. And so you always want to seek medical attention for those reasons. And then we talked about how to avoid that. Well, one would be to get up, how to get out of bed. And for that in particular, you want to do your foot pumps, wear those compressions over the legs. If you can tolerate it, not everybody can tolerate it, particularly patients who have neuropathy or nerve pain. Sometimes that can be very painful. And you can wear the socks, you can wear the sleeves, you can do the foot pumps, you can dangle at the side of the bed. So those are some things you can do there. Sit in the chair, walk to the commode or walk to the bathroom. All those little movements, they really add up. And the less you do that, the higher your chances are for not only getting blood clots, but having to go to rehab after you leave the hospital instead of going home. Then we talked about constipation. And so, we talked about if when you're walking, blood goes to your bowels, and that helps stimulate bowel movements. So when you're not moving, you're going to be more at risk for constipation. So when people are coming in, they've already not been feeling well for a couple of days, so maybe they haven't been eating or drinking. They're coming in with some dehydration. Most people don't eat enough fiber, so that's a conversation for another day. So they're low on fiber, and so what we'll do for that, we'll give them, put them on a diet. If they're able to drink by mouth, that's very helpful. They might also be hooked to some fluid in a bag, connected to a tubing that'll go into the catheter in your body. You might be on that for a few days, especially if you are coming in with dehydration. one of the labs we look at helps us monitor your kidney and your electrolytes, and that can let us know how dehydrated you are. And so we might give you fluids until those numbers improve and until your appetite improves. And we might give you a stool softener or offer it. It might be scheduled or it might be by request. So every shift, the nurse will ask you, when was your last bowel movement? And typically, there's a lot of misconceptions about how often you should have a bowel movement. Our older adults tend to think they need to have one every day, and so they use the laxatives inappropriately. And then some younger people don't think it's a concern at all, and they might only go once a week. And so really 3 times a week is considered normal function. Anything less than that is considered constipation. So constipation is less than 3 times a week. It's also anytime you're straining, if the stool is hard, if you have the urge to go, but it's a very slow movement. And so to combat that, we want to move. We want to stay hydrated. We want to consume fiber in our diet. That can be through fruits and vegetables, particularly if you keep the skin on and if you eat it in its raw form. Because once you start cooking your vegetables, you decrease that fiber. And so you can get it over the counter. You can get it in the form of powders. And I think that's one of the most popular ways they sell fiber over the counter is through powder. But there's a lot of options out there, and there's new ones popping up every week. If you're coming from a very low fiber diet, go very slowly because it takes time for your body to adjust because you can get constipated. But having fiber in your diet is a healthy way to keep healthy bowel function, and it can also decrease your risk for colon cancer. So for constipation, we want you to move, stay hydrated, eat fiber, and then take a stool softener if you need to. There's different kind of stool softeners. They can help literally just soften the stool. They can also attract more water to your intestines, which helps things soften and move. Because on the other side of that, what ends up happening is maybe we need a suppository, or we might do something like a magnesium citrate, which can help stimulate the bowels. We love recommending prune juice. Love that one. Sometimes we do an enema for patients who are paralyzed or who have lost function below the waist. Sometimes we have to do things manually, or the suppository. Those are kind of really the most common things we do there. Then for the blood clot, so for your lungs, we talked about having your lungs expand. And so when those secretions build up and they're not moving out, they can attract bacteria. And that's how we can end up with pneumonia. So again, we want to move, we want to sit up, we want to dangle at the side of the bed, sit in the chair. Every time we need to use the bathroom, we want to get up. All those little movements add up. And so we also might give you a device, which I should have gotten a slide for this one. It's called an incentive spirometer. And it's like a plastic apparatus. It looks very cheap and it looks like it doesn't do anything, but it can save you so much trouble. And it's a device that has like a tube connected to it. And you're going to put that in your mouth and you're going to do these inhales, and you're going to be instructed on how to properly take that big, deep breath. But instead of making them quick and short, we want you to hold at the top. And there's going to be a little something floating in the middle, a little ball in between some arrows that you want to focus on. You want to get that little ball to concentrate in the middle. Sometimes, and I always tell patients, it's not a race. There's no need to rush. You want to take your time, particularly because you're just getting kind of back into the groove of things. You can get lightheaded. You can get dizzy. It can stimulate coughing, which if you've already got a cough or you've got pain or you just had abdominal surgery or even any surgery in the chest area, belly area, can be painful. Coughing can be very painful. And so coughing is actually your body's natural way to open up those air sacs on the bottom of the lungs to get them to participate in air exchange and to help stimulate movement of those secretions so they can get up and out. And I think that covers it. So today we talked about weakness, or what we call deconditioning, and that can just be decreased muscle tone and strength. So once you start moving, you're going to feel really weak, and you might feel short of breath because now you're asking all of your lungs to participate after they've been kind of asleep for a little bit. And we want to avoid weakness because it can increase our chances of not having to go to rehab, especially for our older adults. We don't want to, when they come in, with a baseline of strength. We want to maintain that. We don't want it to get worse. It might not get better while they're there, but we don't want it to get worse. This way they can go back, resuming the level of independence that they came in with. So today's topic was weakness or deconditioning, and it has to do with what happens to the body when we don't move enough. That's it for today. Thank you for watching.